Hey, welcome back to Library Sherry, and today we are talking about what are some common situations will give you a longer turnaround time in Department of Blood Bank. This is the last core analysis department of extended turnaround time series. I gotta say, based on my experience, this is the only batch that I felt like I'm potentially developing symptoms that's similar to paranoia instead of OCD. Today, along I'm explaining why things getting extended turnaround time in blood bank, you will see in this department how important the medical history is compared to all the other departments we have in the lab. I'll be dividing the explanation into two parts. The first part is more focusing on the nature of patient's blood, and the second part will be focusing on our workflow. Start with the patient blood. I'm gonna throw you some jargons: cold agglutinin, warm agglutinin, autoantibody, rulo. Do you know what I'm talking about? No, it doesn't matter. You don't have to understand it. All you need to understand is any of this that I just told you, when they exist in patient's blood, that means the patient blood will just clumps on itself at some steps of our processing. And that brings in a major question for the bench tech who has to working on this patient's blood. Does that clumping coming from the biochemical reaction that I'm trying to do, or is that just coming from the patient blood itself? If I can't differentiate them, how can I give you a result? I can't. So I need to do extra steps to figure out what causes it. So for you, you don't have to understand the mechanism, but for us, we're actually working on the bench. When we see a blood just start to clumping, the first thing we need to do is to identify why it's clumping. We're trying to figure out the reason and then resolve that situation. After the situation is resolved, hopefully we can resume back to our normal workflow, which is giving you the type and the screen. And you may ask, is that something like it's supposed to be in patient chart and you should just know before you start the processing? Yes and no, because here's the thing, some people, these are all the things that can happen at any point of your life without a transfusion history. Some drug will give you interference that is bad enough to just look so similar with all the other conditions that I talked about. The patient blood just looks clumpy. So in that kind of scenario, you will find a very clean medical history of transfusion, pregnancy, and major surgeries, and you won't be expecting that. But then when you're actually doing the processing, things start to show up. Or sometimes what also could be happening is the patient may have the transfusions and the transfusion went very well, but then ever since then the patient was perfectly healthy, never other transfusion or any hospital visit needed afterwards. So we actually unclear what's happening in the middle, and the patient chart just looks like the patient went to hospital, got some treatment, and he got better. Now since he's coming back to the hospital, we need to make sure everything's still good. Some patient may develop an antibody in the meantime, some patient may not. This is where we're trying to figure it out and spending some extra time on figuring out what to do next step. And that will lead us to the next thing I want to talk to you. It's about the workflow. In this bench, one of the biggest thing we need to do about patient is to confirm the medical history. Have the patient ever got transfusion? Was there any major surgeries that may have the transfusion but the patient was unconscious? Was that on the chart? Was the patient transferred from a different facility and they may haven't finished the charting, or we're still waiting for some more information? Has the patient been staying on the floor for not long enough that the previous shift hasn't finished the charting? All. Sometimes we'll be making up phone calls to the floor, and if you got any second of hesitation on the phone trying to tell us, I don't think my patient had a transfusion lately, for any additional second that you hesitate on that line, we generate 10 additional conspiracy theories on the other end of the phone. And the second you hang up, we will blow the phone line to the previous shift, epic chat with the treatment team, epic chat with the attendings, trying to call the previous facilities. Did you fax all the chart, all the history? This is the only department in the entire lab that if we got anything missed on the patient treatment history related to transfusion, it will become a potential cause of death later on when the transfusion actually happens. So yeah, we are all very paranoid on this bench. If there's anything unconfirmed on the patient chart, on the patient history, we will spend a lot of extra time trying to figure out if everything is 100% clear. And before everything is clear and solid, you are not getting your blood. Of course, if your patient is pouring blood to the floor, you may get some emergency uncross-matched O negatives. But for the patient who are not in that kind of extreme situations, we would spend time, a lot of time, just to get things very clear. Okay, so now after we get things very clear, we need to prepare the product. Most of the time, we'll have already defrosted and titrated blood products in our fridge. But there are the times they're running out. For example, if we just recently got multiple calls, multiple rounds of massive transfusion protocol, then our fridge might be very empty. In that point, we need to go to our freezer and start to defrosting all those popsicles. And they take a lot of time. A lot of the hospitals, our defrosting unit is like a water tank just about this big. It's definitely smaller than most people's closet storage unit. But within that tiny little bit of the water bath, we need to throw in those huge frozen popsicles and shaking them in there to make them defrost. It's usually not very long, but 10 to 20 minutes at bare minimum. That's for the frozen products. And for the non-frozen product, at the issuing steps, there are also many things could happen. One of the things a lot of people doesn't know is we are on an extreme platelet shortage nationwide for a long time and won't be getting any better in the future time whatsoever. So what happens now in the blood bank is we are so carefully trying to not issue out more platelet than it need to be. So occasionally if we receive a particularly large unit, we may spend some time to split that into two smaller units. And that will need us to go warm up our little seal machine and then go to cut the lines and seal them and all that stuff. Some hospitals will pre-split the unit before they store them onto the shelf, but some hospitals only waiting until the last second when somebody actually orders the unit and then they will do the split. And now, since we're talking about cutting the unit into smaller units, let's talk about the babies. Because the transfusions for pediatric patients or for intrauterine transfusion, like the babies that's still inside, those kind of transfusions require a lot more extra steps. Besides splitting the unit, sometimes we need to screen the unit to make sure there's no hemoglobin S in there, and that's a test. We need to actually bring a small piece of blood segment and then go to the hematology, tell them to do the screen for us. This test is not normally performed in blood bank. It needs to go to a different department for testing. And what also needs to be done is they need to make sure we are not over transfused, because babies, it doesn't matter if they're still in the womb or not, they're small, okay? They are very small, so you want to make sure you are not blowing them up with too much red cells. So all those dosages need to be calculated very carefully. Everybody needs to stare at the calculation, make sure nothing went wrong before anything goes out from our hand. The other large group need additional process is the transplant patient or the cancer patient. They need the irradiated product. For some smaller hospitals, this might not be ends up with a additional processing time because a lot of time they just order the already irradiated product from the Red Cross or a nearby hospital as their routine storage. But for some hospitals that actually have a irradiator, they will do this step only at the issuing, and that will causing the extra time compared to normal unit issuing. Because once you get the order, once all the cross-match, everything is all done, they will go through a bunch of security steps to go into the irradiation room and throw the blood product into the irradiator and waiting some time for it to be done. It will take some time for the dosage to build up in order to make sure all the white cells inside that unit is killed. And the major purpose for that is to prevent the graft versus host disease, because when you have this happening, the chance of survival is way too low. So we need to kill all the white cells before we give you the product. And now let's get into the last part. This part is also very specialized to blood bank. That is the understaff. Well, I know you may say, isn't that happen to all the department? Yes, but blood bank being specially affected by this part is because to issuing out a blood product, it needs 2 people to read off information together. It can't be just one person sitting there being like, boom, stamp it, saying, getting these things out. That's not happening. You need to have a second person to verify. The amount of safety control in this bench is crazy. This is something that makes blood bank so different from all of the other benches in the laboratory. Any wrong product going out from here, it has a potential to instantly kill someone. So we are not going to allow that happen. So there will never be a situation of just one person working the blood bank and that person just give you whatever the blood products you want. You will always need to have a second person. The most ideal situation is we have 2 people working blood bank, but if not, that person gonna need to go out and grab somebody from other department to come over here, read off the information together. Or that person need to wait until somebody send someone from the floor down into our basement and reading off all the ticket together. And that is not happening in any other benches in the analytical lab. And blood bank is the only department inside the lab constantly giving out physical stuffs instead of just electronic result crossover. So that does make a little difference over here too. Physical transition is definitely always going to be a little slower than the electronic crossover. And at the very end of this video, let's talk about the electronic cross-match. I know a lot of hospitals now start to do that, and the goal for that is primarily 1, increase the speed of cross-match, and that way you can get your blood products a little faster than we do manual cross-match on the bench. 2 is actually for easier inventory management, because especially if you got a really huge blood bank department in a hospital, the inventory can be really crazy. You will have like shelves of hundreds of units of blood sitting in there. With a electronic cross-matching system, whatever the blood products you're taking out or put back, it will instantly be registered inside the system, and you will be easily to know if any blood product is running out or need to order new or expiring, all those kind of stuff. It will be definitely a lot easier than you trying to flipping your chart on a binder. But that is only saving you maybe up to 3-4 minutes on a benchtop pipetting. It is not something would make such a dramatic difference of you getting the blood product or a cross-matching antibody screening result, shorten the turnaround time from 1 hour to 10 minutes. That it is not that drastic difference. So don't expect a lightning speed of product issuing or result crossing over if your hospital later on announced, oh, we are having the electronic cross-match system now. That's not what it is for, and that's not what you're supposed to be expecting. The biggest tip I can give you for getting a result or a product from blood bank as fast as you can is, first, make sure there is nothing missing on your blood collection, your name, date, and time. Blood bank is especially going crazy on whether if you are giving me the correct patient blood sample or not. And you make sure if your patient is brand new to our hospital system, you schedule the second collection for the confirmatory typing. Because blood bank is not going to wait in the lab and stare at their watch being like, this is a new patient, they're supposed to give me a second blood, let me call them, tell them they need to do that. They are not going to. They'll be looking at the type and screen you sent to them and then being like, okay, I got it down. If you don't send them second one, nothing ever gonna happen. They need the second sample if that's a new patient. So if you're gonna schedule a collection for a new patient, you schedule the second collection altogether. And they better be 10 to 30 minutes apart. That way they know this patient is the patient you want to do work on. And the second tip is history. The transfusion history, treatment history, pregnancy history, drug use history, infectious disease profile, anything that can potentially lead a weird result in blood bank on the bench. You make sure all those things are clearly documented in the patient chart, in the epic. If you don't know what drug or what infections can cause the patient to have a result that affecting blood bank result, leave me a comment. You can just easily search it out online or give a call to your own blood bank. Having a clear patient history is the #1 important things you can do to make sure yourself getting the fastest possible blood bank result. Alright, that's all for today's lab rat sharing. Thank you for watching. I'll see you in the next episode.